This closing and opening are not mirror images of each other. They're not opposites. You can't pull a muscle one way and push it back. Someone has to pull it back from where it's been pulled to. So in final closure, if the posterior temporalis has untranslated the condyle, for that final few millimeters of closure that now you can get close to pure rotation closure as you can, but no one seems to care about that. The first few millimeters of opening is not rotation. It can't be. So here's the first few millimeters of opening. Here's the difference of the two. It's not hard to close those last few millimeters. And what would it be like if you couldn't reopen the first few millimeters? What would have to happen? There'd have to be a prolonged contraction of that temporalis. Those teeth were supposed to touch and then reopen. The lateral pterygoid was anticipating, as soon as those teeth touch, man, we got the go signal. And the go signal goes, and so oh, sorry, this is still contracting. Here's a resisted reopening. It's a persistence of closure. The problem is the persistence of closure. That guy is the problem. But when he is being hyperactive, being a problem child, the teeth are in occlusion. We don't recognize that as pathology. We stipulated that. We're waiting for the lateral pterygoid to be symptomatic, and so we start looking at joints that are being strained. We're looking at hyperactive lateral pterygoids. We're looking at facial pain. Forget occluding. That's going to happen. We're trying to figure out what's going to happen if they start to suppress the clenching, start to move around. We start to immediately disclude posterior teeth. And maybe we'll still have some anteriors because we know they're still going to be closed, partially closed. One dentist on Dentaltown wrote on Dentaltown, now this is my quote from Dentaltown, what the stimulus for bruxing in many patients is. This is his quote. He's a very highly respected practitioner nationally. Stimulus for bruxing in many patients is prolonged compressions of the PDL inciting hyperactive muscles to squeeze down and induce more PDL compressions and more hyperactivity and more clenching. He's promoting how to use a T-scan. The TM Da Vinci code on this one, the stimulus for bruxing in many patients is prolonged compressions of the PDL. So that means clenching. So bruxing is clenching, inciting clenching to squeeze down, clenching, and induce more clenching and more clenching. That's what that just said. Bruxism is caused by clenching, which causes more clenching, and which just causes clenching. So if you could just modify the teeth, you wouldn't, no, they'd be clenching. So to say that you can modify the bumps of teeth and not have the teeth come together, it doesn't make any sense. To modify the bumps of teeth so they don't come together. Clenching is the coming together of the teeth. You can't modify the bump if they haven't touched it. How would you know? So now here's this lateral pterygoid. It's primarily a jaw opener. It can influence the path of closure. It's still a dynamic thing. As long as things are moving, everything's okay. When there was grinding side to side as opposed to clenching, at least the joint stays lubricated. If you're moving, you can't be squeezing vertically very hard. It's the person that moves to the side and then squeezes really hard. They've got a joint out to dry, and then it's being squeezed on without lubrication. Excursive clenching is real joint death. As long as something's moving, we're all right. So here's functional masticatory activity closing. The lateral pterygoid is tensing a little bit during closure to avoid the interference. But sometimes after the occluding of these teeth, the lateral pterygoid can encounter a resistance to opening due to a persistence of closure. We haven't shown that yet, but what if this jaw closes and doesn't reopen? Now the lateral pterygoid is trying to reopen it. That interference to closure becomes the resistance point at the attempt at reopening. That right there is the eye of the storm. It's all focused right there. So this interference is typically the same tooth This resistance point is typically the same tooth that was the interference that was trying to be avoided. The interference to this condyle achieving CR, it never got there. So now we have a condyle that's not at its most superior spot. As we start to reverse field and go the other way, that tooth is the primary target. It's the most easiest clenched on. It's the one that hurts the most typically. Now ask me your question. It provides additional circuitry for the perpetuation of temporalis contraction. Okay. If you go and identified that interference with a deprogrammer, because you're going to do full mouth rehab, and you all of a sudden, whoa, look at that interference! I deprogrammed this lateral pterygoid, which had been programmed to avoid it. Bzz, you get rid of it. When they go back to parafunction, that point of resistance isn't there anymore. The next tooth that's in contact might be out here, which is a far less elevation contraction. The elevators are still contracting. We still have a occluding going on somewhere. But you've unplugged the circuitry to the monster. So when you thought you've adjusted the interference to closure and had symptomatic relief, it's not because they chew better, because they parafunction less intensely. The force vectors we'll show in a second in the 3D how they are sometimes aimed away from what's been giving them a problem.